welcome along. This is our first coaching corner of 2021, which I am crossing my fingers is going to be a much better year, but yeah, the jury's out so far. So tonight's topic is going to be the rush exam. So rapid ultrasound in shock and hypertension. Once again, I'd just like to acknowledge our sponsors for these sessions. Philips have sponsored the sessions and keep supporting us in providing these sessions once a month. So if we make a start on the rush, first of all, we're just going to go through a bit of the history and the context, and then we'll take a look at the views and what views make up the rush exam, look at each of those views and some of the normal and abnormal pictures or sonographic images, and then I want to give you a top tip for each view. So your patient presents to the emergency department, or maybe they're on the ward and they're really unwell. They may or may not be able to communicate with you. You might be able to get a history from them, but it might not be so reliable. And you can see that they're exhibiting clear signs of shock. But how do you differentiate what the underlying problem is so that you can direct the management of your patient? So we'll just have a look at those 4 categories of shock to start with, and what protocols were already existing, or what sorts of exams we already know about and may already been doing before you sort of put them all together and get the shock exam. So first we have hypovolemic shock. And so that's where you don't have enough blood circulating around to the organs. The most common cause, of course, is from trauma or from a GI bleed or an aneurysm. But there are other non-hemorrhagic conditions as well that result in the loss of bodily fluids. So the really popular exam that we all know about that you can use for those trauma patients is the eFAST exam. There's distributive shock, and there's no real clearly defined protocol for this. You can use ultrasound to sort of investigate the source of infection in some occasions. So for example, for pneumonia and things like that. Cardiogenic shock, there's a lot of cardiac ultrasound protocols that look at the heart and can give you a quick and clear indication of why or how that pump is failing. And so the cardiogenic shock, the heart can't get enough blood around to the body. What's causing that? Is it because there's an undiagnosed cardiomyopathy that's just tipped over the edge? Or, you know, is there a valve that, again, has just finally reached the end of its life and our body's ability to cope with that? The last one is obstructive shock. And again, we can do a focused cardiac ultrasound here to investigate the causes of obstructive shock. So when you have a physical obstruction of the heart itself or the great vessels, such as in tamponade or tension pneumothorax or a large PE, we know that ultrasound can be used to investigate these conditions. But when you're at the bedside, a lot of those signs and symptoms from all those various different types of shock, there can be quite a lot of overlap, and it can be quite hard to know which way to go. So along came Scott Weingart. Now in about 2006, he was the first one to conceive of the idea of the rush exam. And his rush exam is rapid ultrasound in shock and hypertension. It's been published on his web page, eMed Home, and that was in May 2009. So he looked at the fact that there'd been the FAST protocol. There was a protocol for undiagnosed hypertension. There were protocols for focused ultrasound in cardiac arrest and for shock patients without any obvious etiology. So he combined all those protocols into one simple approach and came up with the rush exam so that you can remember it, because there's nothing like a good mnemonic to be able to remember things. And so it was designed to be rapid and easy to perform on most of your portable ultrasound systems. His rush exam is defined by the sequence of the views. So he came up with this HIMAP because first of all, you look at the heart, then you look at the IVC, you look at Morrison's or the FAST exam, you look at the aorta, and you look for pneumothorax. So it was pulling all those protocols together to come up with this HIMAP. And in more recent times, it's kind of been labelled HIMAP ED, and the E is to look for ectopic and the D looking for DVT. In 2010, we have Phillips Perera, who published a really lovely and informative article, and that was published in the emergency journals, Emergency Medicine Clinics of North America. And his approach to the rush exam, which now was rapid ultrasound in shock, the SH being the shock bed, was to look at a protocol that involved a 3-part physiological assessment of shock using ultrasound. And so you'll be familiar with the terms, the pump, the tanks, and the pipes. And so when we look at the pump, we're looking for causes such as effusion, tamponade, we're looking at the contractility of the heart and the right ventricular size. When we're looking at the tank, we're trying to determine whether the tank's full, whether it's leaky or compromised. And when we look at the pipes, we're looking to see if there's been any rupture of the pipes or if there's an obstruction of the pipes. So originally, Weingart sort of came up with this HIMAP protocol. And when you try to marry these up, you know, the pump, the tank, and the pipes, and the HIMAP protocol, it can be a little confusing. And I must say, I've always kind of interchangeably used rapid ultrasound in shock and hypertension or rapid ultrasound in shock, and hadn't appreciated the finer details of the differences, the very subtle differences between the two. So the pump is obvious, we're looking at the heart. When we look at the tank, we look at the IVC, we look at Morrison's view, which is now an eFAST exam, but when this protocol was conceived, it was the FAST exam. We look for pneumothorax, and, you know, in that extended sort of view, we're looking for an ectopic pregnancy. And when we're looking at the pipes, it's the aorta and DVT. Now, in Weingart's original HIMAP protocol, it didn't include DVT, and I was getting confused about, well, maybe the P's either pneumothorax or pipes, but it's actually sort of 2 different approaches on how to look at this. And I think some of the confusion comes into play because when both of these articles were written in 2006, or these protocols were published in 2006 and 2010 respectively, that was well before we were familiar with the eFAST protocol. And so to the best of my ability to figure these things out, it was about 2013 that it sort of just became, we all became aware of the extended FAST protocol, which also included looking at the lungs for pneumothorax. And so then when you go back and you look at the HIMAP, the P for pneumothorax in Weingart's protocol suddenly becomes kind of without a home because you've already looked at that in the eFAST protocol. So either which way we go, this rush protocol is looking at a patient who is extremely unwell. It's designed to be a B-mode scan. There's a lot of emphasis on the rapid, so the rapid ultrasound in shock. So we don't want to get too bogged down with doing lots of fancy measurements. There's lots of fancy measurements that are possible, but we don't want to get too bogged down in, you know, get into detail of lots and lots of measurements, but rather use some of those measurements, and I'll go through some in a minute, rather use some of those measurements as a way to sort of qualify your B-mode evaluation. And it's designed to be performed in under 5 minutes. And if you listen to some of Scott's lectures, he even advocates that experienced users can perform it in under 2 minutes. So it does depend on how experienced you are, of course. Now, when we're going for a rapid ultrasound protocol, it could be argued that the Morrison's pouch view, or the right upper quadrant view, is as far as you need to go in the FAST protocol, because the right upper quadrant is the deepest part of the peritoneum. So there's going to be fluid, it's going to collect there first. However, when we look at the other quadrants, you can also start to see if there's small effusions around the pelvis that might indicate the ectopic pregnancy, things like that. So we go through those FAST views. So I'm going to go through the next section from a pump, tanks and pipes, because looking at the pathology and how that then plays into your clinical management. So to look at the pump, we're going to use the phased array probe, and there's 3 views that we're going to look at: the subcostal 4-chamber view, parasternal long axis view, and the apical 4-chamber view. On the subcostal 4 view, a very quick image here will very quickly alert you to the fact that if there's any big pericardial effusions or if there's a tamponade. And that, of course, is critical, that needs an urgent intervention. The parasternal long axis view, we're going to look at the contractility of the heart, and the apical 4 is the one we're going to use to specifically look at the right ventricular size. Now, there is overlap in these views. It's not just that you can only look at contractility in the parasternal long, but there's some really quick specific things that we can look for in each of those views that are going to help us answer those questions. So looking at the subcostal 4 chamber view first, we're going to place the probe just inferior to the xiphisternum. We want to use a pistol grip. So put your fingers on the top so that the probe's not slipping off and hitting your patient in the face, but you want to have some downward pressure on your fingers to keep it sort of digging under the sternum. And then go nice and flat with your hand. Now, if you've got a pistol grip, it means your hand won't be getting in the road. And so you can get nice and flat to get that subcostal view. When we're looking at the subcostal 4 chamber view, we can use the window here, the liver here as a window. We have the right ventricle, left ventricle, right atrium, left atrium, and gravity-dependent fluid will collect between the liver and the right ventricle here. So when you see an effusion, you're, depending on how big it is, there's either a sliver of fluid between the liver and the heart, or as it gets bigger, it becomes circumferential and will go around the heart. Now, this is a chap who had lupus, and he'd had a few days with recurrent sharp chest pain and a fever, and his subcostal view demonstrated a large pleural effusion. You can even, maybe not so easily appreciate, but there's a few fibrin strands in amongst there as well. Here's another more obvious example of an effusion that's not looking so good. This is probably built up over time, and this is a malignant effusion. So you can notice here the fibrinous bands in that effusion. And here we've got an example of a very large effusion, and now it's tipping over to be cardiac tamponade. And I've seen a couple of descriptions of this. One is like the John Travolta move with the free wall of the right ventricle doing the John Travolta. And another way I've heard this described is like someone's jumping up and down on a trampoline on the right ventricle free wall there. And here we have another example of tamponade. Another case, and sorry, this image is a little pixely, but it's beauty. It's a hemorrhagic effusion here, or there's a big blood clot in this effusion. Now, our next view is the parasternal long axis view, and this is where we're specifically looking for contractility of the heart. So when you've got a normal heart, it's quite easy to tell that it's normal, but how do I know it's normal, and what do I look for that tells me it's not normal? And so I want you just to pay attention on this view here and look at that anterior leaflet of the mitral valve and how close it comes to the interventricular septum. We can do a measurement there of the endpoint septal separation where you can do fancy M-Mode and take a measurement of the distance from the interventricular septum to the anterior leaflet. And when that is in systole, the anterior leaflet here should come within sort of up to 7 mils away from that 7 to 8 mils away from that interventricular septum, and that shows me that the heart is squeezing and working really well. Now, I'm not advocating that in a rapid or a rush exam that you're going to go and do M-Mode measurements. I think they're a lot harder than they look. But this gives us a way to actually quantify and say, well, actually, no, and look for something specific that says, yeah, it's not really contracting the way we're expecting it to. So have a look at this normal one again. Now, the normal measurement, that anterior leaflet of the mitral valve should be coming less than 8 millimeters away from the interventricular septum. And then when you've got someone who's critically ill and where it's severely reduced and it's really not working, if we look at the anterior leaflet of the mitral valve there, it's miles away from that interventricular septum. Now, another thing you can look for in a normal, well-beating heart that's contracting well, you should see the myocardial wall of the left ventricle. You should see that thicken. And so in a normal heart, it should increase by about 30% in thickness. So you can then put your hand over and just look at the wall and see, does it, as it squeezes, does that ventricular wall get thicker? Again, this is all B-mode measurements. So a B-mode imaging, you know, a rapid ultrasound exam, you don't want to be getting bogged down in doing M-mode and trying to get perfect measurements. You're getting a really quick look and a global picture of whether this is functioning properly, whether the heart is contracting. So an abnormal sort of measurement, if we're looking at it, is over 18 millimeters. But again, it's easier to just say, you know, that's miles away from that interventricular septum. Now, the apical four-chamber view is the next view that we look at. This one's a real doozy to get. I think it's quite difficult. Part of the difficulty here is that your sick patient is often supine, and this view is best demonstrated with the patient lying on their left side. And what that does is just let the heart sort of fall a little bit out laterally so that we get better windows to the heart. But when your patient's supine, you've just got to get whatever you can. So my advice here is pretend there's like a drinks coaster, like you put your beer on, and you need to sort of do a bit of a zigzag around here about the size of a drinks coaster to be able to find the window. Be adventurous. The other way I get to this window is from my parasternal long axis view. I bring the probe down to the apex of the heart, take my probe nice and flat, and then rotate it into that transverse sort of positioning of the probe. Now, when we're looking at the normal right ventricular size, the RV should be about 1/3 to 2/3, which is the LV. So when you have an enlarged right ventricle, those sizes and those proportions get mixed up. So you can see here, on the left here, we have a very large right ventricle. And so then the question is, well, how do I know I've got the probe around? How do I know which is right and left? In this view, in the right ventricle, you have the moderator band. The left ventricle doesn't have a moderator band. So you look for the moderator band here, and that definitely tells you that it's the right ventricle. Now, the other thing to look for here is in the normal heart, the left ventricle is the one that should take up most of the space when we're looking at the apex. Whereas you can see in this, this right ventricle here, it's the right ventricle taking up most of the apex. So let's look at that side by side with normal, where here we have the left ventricle forming the bulk of the apex. This one, we have the right ventricle. So that tells me that this right ventricle is enlarged. Now, if we go down the fancy measurements path, you can take a TAPSE, which is the tricuspid annular plane systolic excursion. We're looking at that tricuspid annulus, and when the heart is beating, that annulus is jumping up and down here. So the normal amount of movement is bigger than 17 millimeters. And when the right ventricle isn't working, it's less than 17 millimeters. Again, yes, you can do these fancy measurements, but if you just start to look at the B mode and look for these signs and symptoms, you can start to get an appreciation, even without measuring it, that that is or isn't working. So we have normal on the left, and we just want to focus in on this annulus as it goes up and down and how much excursion of that annulus there is. Whereas over here on the right, we have an abnormal one, and there's just not as much movement of the annulus. So that then leads us on to the tank. We want to look and determine whether the tank's full, whether it's leaky, or whether it's compromised. So again, the views that we know to look at here, we use the curved probe to look at the IVC and the bulk of the eFAST views, so the abdomen part of the eFAST views, and then we use the linear probe to look at the lung component of the eFAST views. Now the IVC, we put our probe on in a longitudinal orientation. Now it depends if you've got your probe in cardiac, if you've got your machine in the cardiac orientation or the radiology orientation, which way which side of the screen your heart's going to be on. As long as you know what you're looking at, don't get too hung up on it. If you're in a cardiac orientation, I think the image is upside down, but that's because I trained general. So we had the heart on the right of screen and the head on the left of screen, I should say. So when we look at the IVC, you can either go from your subcostal 4-chamber view and then rotate on it to get into the longitudinal orientation where you have quite a steep tilt on the probe, so you're looking up under the heart. Or you can do from an abdominal approach, find your aorta, which is midline in longitudinal, and then just tilt out to the right-hand side to find the IVC and rock your probe up so that you're pointing the probe up towards the heart and you see the diaphragm on the edge of the screen. Now, when we're looking at the IVC, it's quite well known. You can look at the IVC to assess the volume status of your patient. And there's been lots of debate around, you know, some were proponents that if it was collapsing by more than 50% and it was measuring bigger than this, then you could assume a right pressure of X. I don't know. I've seen so much variation in the normal IVC. And then of course it depends if your patient is ventilated or not. And then you've got to do things slightly differently. I think after all of the argument that's been out there about the IVC, I kind of think at the extreme ends, is it empty or is it full? It's helpful. The degrees in between, I don't think matter so much. So is it empty and you can afford to give some fluids, or is it completely full and giving fluids is only going to further compromise the patient? So here we've got a normal IVC. So what we're looking for is that during normal respiration, there's a bit of collapsibility of the IVC. When the patient has not got enough fluid on board, you can see that that IVC is really quite flat and it's really hard to find it. And then when you have, and so that's the hypovolemic patient, and then when you have someone who's in congestive cardiac failure, or maybe they've got a big PE, you see that the IVC is quite distended. And if you look up through into the hepatic veins, they're also quite large. And so when the patient's on overload, you don't get the IVC collapsing, it sort of stays distended and you don't get that respiratory variation in the size of the IVC. So moving on to the fast component, the right upper quadrant, you put your probe around on the mid-axillary line, and we're looking for free fluid in the peritoneum. So typically you're looking in Morrison's pouch, but while we're here, we're also going to just sneak the probe north and get a view of the base of the lung to see if there's any evidence of a hemothorax. So my top tip here is run your hands, or put your middle finger on the xiphisternum and run that around so that you get the height right around to the edge, and where your fingers sort of touch, come into about the mid-axillary zone, mid-axillary line here, and then put your probe on. That's going to be at about the level of the Morrison's pouch. What we need to do then is not kind of crazy hands it and hope that we can just find a view magically. I want you to be quite systematic and thorough and paint the fence. So we're going to go anterior and posterior, and then we're going to move up a rib space, and we're going to repeat that and paint the fence again here, anterior and posterior. And that'll get me just under the diaphragm. And if we go up another rib space, we'll see the base of the lung. Now, in doing this quite systematic search, we need to assess the whole area, not just plonk the probe on and hope that it's right. We want to systematically search for a good window. So I don't know if anyone's been watching Cobra Kai. I'm a bit of a fan, and now we've run out of episodes again. But they do, it's based on the old Karate Kid and this paint the fence. So when you're evaluating the right and left upper quadrant, you need to do this paint the fence. And the fence palings here are the rib spaces. So do one rib space, move up a rib space. So when you do that scan, you can see it comes in and out of view behind the ribs. And then we move up again and look up here. So you want to, I'm just going to go back to this one. Start here, we've got the kidney, move up a rib space, paint the fence here to find a good window, move up a rib space and paint the fence again. Now the thing here is that if you have to take one still picture, yes, you can find a good window and you just take that one picture as your representative image, but it's really important that you're scanning the right upper quadrant and you're not just taking pretty pictures, because you need to evaluate pathology rather than to take just nice, pretty pictures. The pictures that you are taking need to tell the story of the patient on the day. So the places to look for the fluid is in Morrison's pouch here, or the hepatorenal space. We look around the tip of the liver, and then we look under the diaphragm and above the diaphragm. So when we have fluid, there's a band of black tissue, and about 1 centimetre in thickness is about the equivalent of a litre. And if we look at this base of lungs view, you can see that we can see the spine keep coming up here, but we've got quite a lot of fluid here above the diaphragm that indicates a hemothorax or a pleural effusion, depending on the clinical history. Now, the left upper quadrant, same sort of thing. We're going to come down from that xiphisternum, but we're going to go all the way to the back, to the posterior axillary line this time. So I recommend, as you're leaning over, the back of the hand is on the bed. Then all I'm going to get you to do is rotate your probe so that the top of the probe points to about 1 o'clock. 12 o'clock is the armpit, and we want to rotate that probe to about 12 o'clock. Then tilt your probe up and down to find your window, and again, paint the fence. This is a picture that I took on a very normal person, but all it is going to show you is the difference between having my probe at the 12 o'clock position or in true longitudinal, or just rotating my probe around to that 1 o'clock. Rotating it around to the top of the probe around to the 1 o'clock just pulls the spleen out from in between the ribs, and you're kind of aligning your probe with the ribs. And from there, again, paint the fence. You're searching for a good window here, and you want to scan the upper quadrant, not just one slice. So when we do this paint the fence technique, you can see at times it's not such a good image because we're looking through assessing for fluid in the region. When we have free fluid, we're looking under the diaphragm in the splenorenal space, and we also want to look around the tip of the spleen around here as well. Now the pelvis, my top tip here is put your probe in longitudinal. Slide the probe down so that the bottom of the probe butts up against the symphysis pubis, and then point your probe directly to the floor. When you do that, directly underneath the probe will be the bladder, and deep to that will be the uterus and vagina, which makes like a Nike swish sign or a tick sign. That's kind of like an arrow pointing to where the free fluid is going to collect posterior to the uterus. So over here on the ultrasound image, we have the tick or the Nike swoosh, with the long stem of the tick there being the vagina and the short stem being the cervix. And that's like an arrow pointing to where pouch of Douglas is and where the fluid collects. We then want to make sure that we're scanning the pelvis, not just plonking the probe down in the midline and hoping that fluid accumulates in the midline. If you have a patient that has pelvic scarring or adhesions, they might have endometriosis, fluid might not collect in all the typical spots. So you need to assess the pelvis for fluid. So go from the right iliac vessels and scan over or sweep over to the left iliac vessels. When there's free fluid, as you can see, bladder up here, this is an enormous bladder, someone's very full. And then we've got the uterus, vagina stripe just here. And then deep to that is the pouch of Douglas. And this is an extreme case. There's lots and lots of fluid here, probably in someone more likely to have ascites, but the fluid then conforms around and it makes the bowel look like seaweed almost, or kelp, and you've got the fluid sort of fitting in amongst all those, forming sharp angles with things, fitting in amongst everything, filling up all the spaces. Now in the male pelvis, same thing, put your probe on in long, bottom or the heel of the probe butting up against the symphysis pubis, and point your probe directly to the floor. You have the bladder, and then now the bladder makes it look like an arrow, which is pointing to where your fluid collects through here. Now, the last view of the FAST exam is the subcostal fall, but we've already covered that in the heart. So it's all the same things again, same points. We're looking for tamponade. You can look at the squeeze of the heart here. You can even get a good idea of the ventricular sizes. So then we move on to the lung part of the eFAST exam. When we're looking at the tank, we're looking for compromise of the tank. And so we can look for pneumothorax. We pop the probe on in longitudinal. I always go in a longitudinal view so that I've got the rib shadows as round landmarks so that I can find the pleural line quite easily. If you put your probe on in transverse in a hurry, it's very easy to confuse the rib or as the pleural line, and because they're both bright white, the pleural line and the rib are both bright white. So the rib has dark shadowing, the pleural line has dirty shadowing, but it's easy to make a mistake between the two. So if we keep our probe in the longitudinal, we want to just run it down the anterior part of the chest there. If there's a pneumothorax, the patient is supine, hot air rises, and that's where we should see a pneumothorax. And then repeat the same thing on the left side. It's interesting, one of our patient models the other day was ever so kind. It had a bit of chest pain, but didn't think much of it. But he had a spontaneous, healthy young chap, 21 or something, had a spontaneous pneumothorax. And it looked enormous on ultrasound, but he had an X-ray and they could hardly see it. So it just goes to prove how sensitive ultrasound is for picking up pneumothoraces. You can use either the curved or the linear probe here. If you're in a hurry, the curve is certainly going to do you well. I'm not a big fan of the phased array for looking at the lung. I think the near field resolution is not good. It's designed to go deep, so it doesn't give you such great pictures. But, if you only have one probe or you're in a real hurry, the curved probe will get you really adequate pictures to determine if there's a pneumothorax. But of course, the linear probe is the preferred option. So here we've got those linear and curved, same patient, and just having a look at the lung sliding here. And certainly the linear probe, I think, makes it a little bit easier to see. And you can see the rib shadows. So they're my landmarks to determine where this pleural line is. So as I said, I always go longitudinal, and that's because I've got the rib shadows as a landmark. So we have the superficial or the adipose tissue here. We have the muscles of the chest. We've got intercostal muscles. We have the ribs here. And then just deep to that is the pleural line. And it should slide. And we have essentially what we see is the visceral and parietal pleura sliding over each other. And so it's like ants on the fence. So here's an example of a normal lung and the lung sliding. And on the right, we have a pneumothorax. And so here's the rib shadow, and the rib shadow with a loss of sliding here of the pleural line. Now we can see the respiratory effort going in here, and we can see the movement of the intercostal muscles in their effort to breathe. But you don't see any sliding of the pleural line here. Now you can quickly, it's not really officially part of the rush, but while you're on the lungs, you can also get a quick gauge of how wet they are. If you're looking for the number of B lines, if you've got vertical, the normal lung, you have A lines. If you've got vertical artifacts coming down or B lines, depending on how many there are, versus when it's coalescing here to be one sort of big waterfall, it's getting increasingly wet lungs, and ultimately that leads to effusions. So you can quickly, while you're there, take in, are the lungs wet or not, and is the pleural line smooth, or is there signs of pneumonia? And last but not least, we get to the pipes. We're looking to see, are the pipes ruptured or are they obstructed? So the first part of that is with the curved probe, looking at the aorta, and then we move on to the DVT, and we're using a linear probe. So the way I approach the aorta is to start in a transverse position just above umbilicus. The reason I start here is because the bowel loops here are quite compressible, and you can put on a little bit of pressure and find your vertebral shadow nice and easily and just get your bearings around where things are. I find if people just start straight up under xiphisternum, often the transverse colon is obstructing the view of the aorta, and people get stuck on the transverse colon and don't move and then don't see anything. So if you start in the soft part of the belly and then slide your way up to xiphisternum, and then from here do a 10-second sweep. So we want to just keep the probe moving slowly and steadily from the xiphisternum all the way down to the bifurcation and the iliac vessels. So you can see here, as we do that 10-second sweep, the aorta sort of disappears behind the bowel gas at times, and you just wait for it to pop out the other side. It goes away, comes back here, and there's the bifurcation. The key landmark here is to identify the vertebral body. I have seen the vertebral body measured as an aneurysm before and have heard a case where it went to theatre. You don't want to be that person. So if you find the vertebral body first and then your aorta in reference to that, the vertebral body here is also a good indicator of the aortic size by just eyeballing it. If your aorta is smaller than the vertebral body, you're probably okay. And if it's as big or bigger than the vertebral body, you have an aneurysm. So on your very slim patient, you don't need your depth set too far and everything's very close to the surface. Your average patient, you might need your depth set at 10 centimeters or 15 centimeters or so. And I tend to be a bit more generous here so that I don't have to change my depth too much as I'm doing that survey scan and that 10-second sweep from the xiphisternum and down. And your larger patients, you need a lot more depth and everything is just so much harder to see. So we've got the vertebral shadow here and then the aorta sitting just in front of it. So as I said, the 10-second sweep. Keep your eye, find it, keep your eye on the prize here, and then it comes in and out from behind the bowel gas as you're going down. And in 10 seconds, you have an answer about whether there's an aneurysm. The beauty of the aneurysms are that it's big fluid-filled mass, and so they're very easy to see. When we're in longitudinal, my top tip is make sure you rock your probe up under the xiphisternum. You'll get to see about an extra 5 to 10 centimeters of the aorta and maybe sort of pick up those proximal DVTs. If you just stay perpendicular to the bed, you're missing the proximal portion of the abdominal aorta. So start your exam with the probe tilted as displayed on the right there. And as soon as you've seen diaphragm and a bit of wriggle of the heart on the left side of the screen, then we want to rock back down so that everything's horizontal again to increase our chances of picking up a dissecting aneurysm. So here's some examples of an aneurysm. We've got a nice flap. You might recognize this one, Alan. Thank you. And then another one over here with a mural thrombus. And so be careful when you measure this that you're not measuring the lumen. You need to measure from the external wall and edge to edge this way, all the way out and include the thrombus. So you want to go to external wall to external wall.
On that,
now when you have a
Sue-Ann, just on that picture, if you just go back to the one that you were just on, the one on the right side of the screen as you look at it, so not my case, but the other case, that fluid to the left, is that outside the wall or is that, I mean, that looks like it's outside the wall. It's not part of a flap, is it? That's outside the wall.
No, I think that's outside the aorta.
Because it looks,
because you can track the wall of the aorta coming around here.
There's no visible wall out beyond it, is there? So you would definitely say that, like, not that you can prove that, not that you can disprove that they're leaking on an ultrasound, but on this case, with that image, you can prove that it's leaking.
Well, yeah, because this looks like, you know, it forms sharp angles here.
Yeah.
And so, I mean, you don't want to push that too hard to test the compressibility of the IVC. But, you know, an IVC will still keep its shape as you track up and down, whereas this won't be sort of vascular in shape. So, you know, if you're, push the play again, see, as you come down a little bit there, it starts to look more like IVC and looks like it's round. But see how that one still image can convince you of lots of different things. And the importance is to take images that tell the story, the true story of what was happening. So if I just play that again, Sam, you can see there that it starts to be very clear that that's IVC.
Yeah, you're right. Yeah.
And we see it nicely because this big aneurysm is actually making a nice window for us now. And so we see it in much better definition than we otherwise would.
Yeah. Thank you.
So the dissecting aneurysm, these can be quite tricky. You don't necessarily get ballooning of the vessel. So they may, and most of the time they'll maintain the vessel size, and what you're looking for is the intimal flap. So you can see the two channels in this. It gives me palpitations looking at it. And we have another example over here. And you can see the intimal flap bouncing around. Now, this needs your gain settings to be set correctly, and you need to be perpendicular to that flap to be able to see it. So if you had too much tilt, like trying to get too proximal, you might miss that flap. So that's why you need to kind of, yes, tilt to look up under the ribs and get that proximal part. But as soon as you've seen that, come back down and make your aorta horizontal on the screen so that we know that we're getting specular reflection and increasing the chances of detecting a dissectional flap. Now, the last part of the pump, tanks and pipes is the DVT. And I start in the groin here, then I track my way up as far as I can see the vessels, and I'm compressing as I go. And then I track my way down the leg, and usually I just have the patient's legs that have rolled out and bent up a little, and then looking behind the knee. Now there's some, we used to do like the 2-point study, but they've done quite a bit of work sort of saying, yeah, you can have quite a lot of clot happening through here. And the annoying thing about the clot that happens through here, this part of the leg is really, really hard to look at. And so there's a couple of things you can do. And what we need to do as we're testing to test for DVT is just slide our probe down just a little bit, not over exaggerate it, and compress a centimetre more, compress, move it down, compress. So if we look in this next one, you can see that technique. Slide down a centimetre or so, push. Now you can see as you come down to this mid-thigh, if you put your other hand underneath their leg and then push the tissue up towards your probe while you're compressing, it not only does it bring your vessel closer to the probe and you get better detail, but it makes it easier to compress as well without sliding off the patient. So when you do this compression on the normal scan, we need to push, push, push. We need to make that vessel completely collapse so that the opposing walls kiss each other. And you can see as we continue the exam down the leg, it kisses, it completely goes away, and then completely goes away. So every centimetre or so, we're just pushing, move along, push, move along. So here it's normal proximal, and as we keep coming down, we start to encounter trouble about now, and now it doesn't collapse. So when we push, it's not closing. So if you think about it, happy veins wink at you, and there's no lazy winking. If it's lazy winking and it's not completely collapsing, there's something obstructing the vessels. So happy veins wink at you and sad veins stare at you. So that's the whirlwind tour of the rush exam. We first look at the pump, or if we compare that with the HIMAP protocol, so the pump is the heart, obviously. The tank, we look at the IVC and assess volume status. We look at Morrison's pouch, looking for any signs of free fluid, and is there any leaking of the tank. We look for a pneumothorax to see if the tank is compromised in any way. And as part of that, while we're down in the pelvis, you can also look to see if there's free fluid in the pelvis or to confirm if there's an intrauterine pregnancy or not. And again, that's more about ruling in an intrauterine rather than excluding an ectopic. And last of all, we look at the pipes, which is the aorta, looking for an aneurysm and rupture of the pipes, or for DVT, looking for obstruction of the pipes. And so you get the Weingart protocol, if you like, which is HIMAP, which is sequencing the views and giving us a nice mnemonic to be able to remember them, which has evolved into the HIMAP ED. And then you have the pump, the tank, and the pipes of Phillips Perera's model, which sort of looks at it from a physiological standpoint. So I hope there's been some tips in there that give you pause for thought that you can try when you go back to your workplace. But has anyone got any questions at this stage?
So, Anna, I think that's been a really great overview of the rush exam. One thing I would comment on about is that very often we do have some history to help guide us right off the bat. And we generally, even before we pick up the probe, have some clinical suspicion as to what we think might be the cause of shock. And I think a lot of us in practice will cater our first look at what we think is the most likely. So if you think it's a ruptured ectopic, you're going to look, into the pelvis. If you think it's cardiogenic shock, you'll probably look at the heart. If you think it's tamponade, you'll look at the heart. Ruptured AAA, look at the obviously the aorta. If you're not sure, I don't know. Yeah, I just look at the heart, because usually the heart will tell you kind of the cause of shock, because if it's flailing away and the ejection fraction is 100%, well, it tells you it's probably, hypovolemic or potentially distributive shock. The trouble, of course, is ultrasound in the vast majority of patients with hypotension and shock isn't overly helpful, because it's usually sepsis is the number one thing that we see in Australia as a cause of shock. But every once in a while we get lucky, and I don't know what other people think who are on this podcast or forum, whatever you want to call it right now. Every once you get lucky and you find something you did not anticipate, like a tamponade or a pulmonary embolism. I'd be interested to see what other people think.
I was only just going to make a comment about your Karate Kid clip, in that I actually, obviously some of us on the call are old enough to remember the original version, but and the initial one. But I actually used that movie to describe FAST in a slightly different way, in that you see people doing the wax on, wax off movement, sort of like this, because they don't quite know where to place the probe for the right upper quadrant and left upper quadrant view. So I sort of tell them, this is the Karate Kid sort of technique. And I try to give them that sort of rough landmark technique of putting your middle fingertip on the Ziffy sternum and lining up with your middle finger for the right upper quadrant and lining up with your little finger for the left upper quadrant. Because anyways, as I said, it's interesting because you've used the Karate Kid clip in another way about making sure you fan, which is great. I didn't think of that. I just thought of the wax on, wax off one.
You see, you're a bit of a karate follower there, Alan.
I'm nowhere near the Karate Kid in level, I can tell you that.
No, I think the importance of that is just in the painting the fence. And too often I see in novice users of ultrasound is that they put the probe on the skin, and they may or may not get a good view, but they're a bit scared to move it in case they lose the view. And so I just am trying to emphasize this systematic paint the fence, to search for a good window and to find the best window that's available, but also as a way to scan the right upper quadrant rather than scan the mid axillary line plane only and just stop there and go no further. So it's more to get you moving and not being afraid to move your probe, finding a window, but to systematically look through the area.
Yeah. And the other thing I say to them is, I think the way they hold the probe is really critical for a FAST scan. And I'm sorry, I wasn't at the start of the talk because I had my karate lesson on, but and I think that if you haven't got the right probe grip in FAST, you're pushing the proverbial uphill, because I really say to them that for the right upper quadrant, if you're not getting a good view because of the bowel gas problems in both sides, you really need to move the probe more sweep the probe more posteriorly, and then offset that by fanning anteriorly. And you can't do that if you've got the traditional sort of fat pen grip. And that's where I emphasize, you want to have it resting in your hand so that, your index finger is against the skin and you can really get your hand back into the bed. And then the same on the other side for the left upper quadrant is, again, have the probe resting flat on their hand with a little finger against the skin, because I think they're not getting a view, as well as making sure they're sweeping through the area. I think it's critical that they are able to position the probe into the bed if necessary to avoid the bowel gas. And then, because they've got to learn 4 grips for FAST, I think, to work really well. Absolutely. And also it's comfort. If you're not holding the probe for the right upper quadrant, you're holding a fat pen, isn't it? You can never get the bed at the right height. You're sort of squatting and you just don't feel comfortable. So I tried to teach the 4 grips, which are distinct for the right upper quadrant, left upper quadrant. Pelvis is your traditional grip. And obviously we all know for the subcostal cardiac or eFAST subcostal, you got to have your hand on top, haven't you? But I think grip, I really emphasize it in eFAST more than any of the other scanning techniques, is how critical it is.
Yeah.
What do you reckon, Brian?
Oh no, I agree. I think a lot of us, as you get experience, you sort of get intuitive as far as how you end up holding the probe, and it's always really interesting teaching novices because they just look so uncomfortable when they're holding the probe, and it comes with time. One thing along the same lines that Sue-Ann mentioned, she mentioned that the right upper quadrant view was probably the most sensitive or easiest to pick free fluid. Now, I would probably agree with that. I guess the caveat is every once in a while we'll have somebody walk into the emergency department with a ruptured spleen from footy. And all the blood's in the pelvis, you know. So I think the patient positioning is important. So if they're sitting up, you know, I think it's getting really good at looking at the pelvis is helpful. And one quick question for you, Sue-Ann, because just my last shift, I had a ruptured ectopic pregnancy where there was, I couldn't find the fluid in the pouch of Douglas, but off to the left at nexa in between bowel loops, there clearly was free fluid. You know, I had to scratch my head a few times, but it was definitely there. Is that something you see from time to time?
Yeah, and I think it's, I'm glad you raised that because I think traditionally the eFAST view and all the pictures that you see that are stills are that midline view. And we get focused on just plonking the probe down and producing that one image. And ultrasound is, I mean, it's really nice to have pretty pictures, but it's about doing a good scan. And the thing with fluid in the pelvis, I mean, you don't know if your patient has endometriosis or scarring from previous surgery. If there is scarring or endometriosis, fluid's not going to collect in conventional ways. It might be that the pouch of Douglas has got adhesions in it. And there's a lot of stuff being done now on deep infiltrating endometriosis where you, on a transvaginal exam, we look for adhesions in the pouch of Douglas by just moving the probe and giving everything a bit of push and a shove so that we can see the uterus and the bowel sliding over each other. So if that wasn't happening, there might be adhesions there, and so the fluid will go where it can get to. If one pocket is sort of sealed up, it'll go somewhere else. And look, often you might only see fluid in the right upper quadrant. You know, if that's where they've been lying, the right upper quadrant and Morrison's pouch is the deepest part. It's the bottom of the bucket. So I'm not surprised at all. I think we just get conditioned to, here's that view. I put my probe here. I just want to do one view. You're trying to do this in 2 minutes or so. You're under the pump, and it's easy to kind of cut corners and not perform a scan. And I want to emphasize the importance of scanning rather than just collecting views.
I have
now, Rajesh. Sorry, Rajesh had his hand up there. Sorry, Alan, I'll come back to you.
Okay. Oh, hi. Thanks, Sue-Ann. Just following from the comment about right upper quadrant being where the money is, and I agree. And also, we just need to keep reminding the novices and the trainees that unless you've actually looked at the tip of the liver, the caudal tip, so your FAST is really incomplete. And often that's where fluid, especially in trauma, in our experience, we've missed so many. So they just look at the bit of that recess, a bit not really behind the diaphragm, which is fine. But unless you really scan the tip, which they're not really used to because they haven't been sort of really trained on that and not sort of got that critical eye and plus that sort of experience and knowledge. So unless you finish that off, your FAST is really incomplete from yeah, that's what I would probably re-emphasize.
I guess, again, the picture that we're used to looking at in the textbooks that says FAST positive or negative is in that splenorenal space. And we've been conditioned to go, it's Morrison's pouch. So I'm looking between kidney and liver. But you're right, unless, and again, it's about performing a scan rather than just getting a picture, one pretty picture. The scan is, I mean, it's like looking at your CT exam, for example. We don't want to just take one image at one slice and be able to infer normal throughout the whole abdomen. The CT exam is built up of several slices that we need to put together to form a whole picture. If we just put the probe on and get Morrison's pouch, that's like trying to infer normal from just looking at one image on a CT scan. So in ultrasound, you have to create the slices by moving your probe. And so, yeah, I can't stress enough, it's about performing the scan and evaluating the right upper quadrant more than it is about getting one picture of Morrison's pouch. And it does sort of, the fluid does sneak down and go around that tip quite often.
But that's very good analogy you used about using the CT slices, and also I think that's something I'm taking out of this today, and I'm going to start sort of talking about like this in that fashion, because it'll be more comprehensive for to them in that way, rather than if I just tell them you have to do it.
So I have a lovely slide for that too, Rajesh. That teaches that point. Anyway, Alan, you were going to say
just
something.
Another point on
sorry, Rajesh.
Just a quick one on the grip. I think Alan's talked about it, and it's so much important about the grip. And as you said, different grips and different sort of views and all that. I've seen people finishing term 6 months of ultrasound and still holding it like sometimes holding like in a hammer, or even like a big pen and all that. So I've actually been a live model, and I remember if you have a bad grip, you're going to actually get your patient in you're going to really give them grief. So it really causes soft tissue, decent pain for the next couple of days.
Yeah. Yep. We really harp on probe grip in our courses, because it's so vital for getting good pictures, whether it be the 4 different grips in the FAST exam, whether it's when you're looking, holding the probe low enough so that you've got it in your fingertips and you can actually control it. It's incredibly vital, the probe grip, when you're doing vascular access, that you're not holding it like a dead rat, and that you're holding it low enough and you can anchor your hand position. That probe grip is super important.
I was just going to say two examples of where the fluid can end up. In that we had a patient in our short stay that I got asked to scan, and he'd fallen off a mountain bike and walked off the mountain in Mornington Peninsula down to our hospital at Rosebud at the time. And even though his injuries were all on the left side of his chest, sort of left upper quadrant, and he ended up having a smashed spleen, it was very subtle to see the fluid and the splenic injury on that side. But because he was so sore on that side, he'd been laying on the other side in the bed for like an hour and a half before I came to see him. And it was easy to see the fluid in the right upper quadrant. So, you could tell straight away something's going on. But, your natural instinct was to be looking hard in the left upper quadrant, but he'd been laying on the right side. And that was obvious when you asked him. The other thing that happened to me the other day is a spontaneous pneumothorax patient. I'm still not sure whether we missed the pneumothorax or not. He was laying, I don't know why my registrar was scanning him supine, but he didn't want to move the patient, and I didn't argue with it. And I said, well, you need to look in the nipple area. We're in the midclavicular line on the right side. And I'm still not sure whether he missed it or not. But when we looked at the CT, it was interesting in that the pneumothorax was medial to the midclavicular line up to basically the midline of the body. And so I think that explains why we missed it. But then I said to him, look, don't feel too bad. I don't feel too bad, because ultrasound's not designed to miss a tiny pneumothorax that was like 5% in size when he's laying on his back. And it didn't change the management, obviously, apart from his follow-up. So, but I found it interesting that it didn't even cross the midclavicular line when he was laying on his back.
I think something that you prompted in your comments there, Alan, I remember doing a case at the Alfred Hospital, young girl who was a 19-year-old involved in a motor vehicle accident, and she was your perfect ultrasound, like lovely and slim, really beautiful views. And I remember thinking, oh, is there free fluid in that left upper quadrant or not? Yeah, I'm not really convinced. She went round to CT, and her CT, and we could see nothing. We would have called left upper quadrant normal. Her CT showed that her spleen was completely smashed, and the spleen looked normal on ultrasound. So it just highlights, and I was staggered by how smashed that spleen was and how normal it looked on ultrasound. But it just emphasizes the point that as much as you see free fluid, and you hope that you can see it in all those cases, that it's not indicative that your organs are haven't been injured or completely beat up. So I was really shocked at just how smashed that spleen was and how normal it looked on the ultrasound.
I think you're right. Until you see a case with your own eyes where you think, I didn't really like, my case, I could see some little tiny line going into the spleen. I thought it didn't look right, but I never could have guessed it was as smashed as it was. And I thought those books can't be right. It can't be that bad
Exactly.
that you're missing it. And I go, oh, I'm a believer now. I'm a total believer now.
Well, I'd read that line in the articles that it's not indicative of you can't exclude blunt injury to the organs. And yeah, then you see the case that proves it. Now, does anyone else have any other questions or comments at this stage? Well, thank you all for joining us on our first Coaching Corner of 2021. And I'd just like to acknowledge again the support and sponsorship from Philips Ultrasound. We have a lot of fun playing with their machines. They have their machines at our place for you to practice on. And a lot of my images that I've taken in this have been taken just on the little handheld and on the Lumify system. So thanks to Philips. And if no one else has any questions, we might ring off and say good night.